Yes, that's correct.
Okay, great. So wonderful. So this is Anastasia Dodson from the Department of Healthcare Services, and I am very glad to welcome everyone to the kickoff meeting for the CCS Redesign Technical Work Group on County-State Roles and Responsibilities. And let's see. So I don't think I can advance the slides, but Jessica, you can. Is that right?
So you should be able to, if you see the navigation pane at the very bottom left-hand corner of the screen, there's a left and a right arrow.
Very good. Okay, good. So I've advanced it to the welcome, introductions, and roll call. Jessica, do you want to do the roll call, or did we already? I think we essentially did it, correct?
We did, but the webinar wasn't recording yet, so I think it might make sense to do it again, to just run through the member list. So I'll go ahead and walk through the member list just to do a quick roll call of who's on the line. And then, so the co-chairs, I'm going to go ahead and navigate back to the slide. So the co-chairs for this group are Anastasia Dodson, which I know is on, Luis Rico. Are you on?
Yes, I'm here.
Hi, Luis. And then Judith Regal.
Yes, I'm here.
Great. And then the members, just to again run down the list, is Diana Apostolos.
Yes, I'm here.
Susan Mora.
I'm here.
And David Zulelis.
I'm here.
Great. So those are the members. I'll go ahead and hand it over to you again, Anastasia.
Terrific. Okay, so I will advance to the next slide. And just to, for folks who may not have joined any of these webinars previously, there are 6 work groups that are part of our overall redesign effort. We have a larger group, which is meeting every other month, and then we have a series of technical work groups that are meeting more frequently to tackle more narrow topics and to make some progress on those topics and then report back to the larger work group. The next larger work group meeting will be in May of 2015. So again, this particular technical work group is focused on the state and county roles and relationships. The other technical work groups are, there's one on data, another on eligibility and health conditions for CCS, another on outcome measures and quality, another on provider access and provider networks, and then the 6th is health homes, care coordination, and transitions. And just a side note that the health homes, care coordination, and transitions work group will be meeting tomorrow morning, Thursday at 9 a.m. So a lot of activity going on these technical work groups. All right, so I'm going to advance to the next slide. And this slide is discussing the roles and responsibilities of our work group. As everyone knows on the call, the CCS program is administered as a partnership arrangement between the state and counties. And there are lots of complex fiscal interactions as far as how the funding streams work together to fund county activities and overall payments for CCS diagnosis and treatment. So there are, as the slide is describing, Title V, Title 19, Title 21 federal funding sources, and Title 19 and Title 21 have associated non-federal shares that are shared by the state and counties. So with this complexity then is a very closely tied relationship between the state and counties in the funding streams and in the joint administration of the program. I'm going to go to the next slide. So, and again, this is just sort of the overview as we think about this work group. There are some changes to the program that have been implemented statewide, and then some that have been implemented or modified from county to county that sometimes affect funding or service authorization or eligibility determination. And so you're probably all aware of various examples as far as San Mateo and Rady Children's Hospital for the CCS pilots, and but there are other types of efforts when we look at the carved-in counties partnership health plan, and as well as I believe Santa Barbara. So thinking about what the county and state relationship looks like there, if there's any difference there. So this work group is going to be looking at assessing areas for improved consistency and clarity of roles and coordination. So there is a lot of intersection between this technical work group and the other groups, the meeting tomorrow on medical homes, care coordination, and the other work group that we have on CCS eligibility. So we'll try to be as coordinated as we can across these different work groups, but there are some topics that are just for this work group that is not necessarily overlap with other groups, so those are the topics we'll try to keep this group focused on. So I'm going to go to the next slide. And so this next slide 6 has some further details in bullets on some of the more detailed topics that can be addressed through this work group. As we think about, again, the larger perspective, the purpose of this overall CCS redesign effort, I hope everyone is familiar with the goals that the Department of Healthcare Services has put out as far as whole child care and organized delivery systems. And again, just keeping in mind that larger perspective and goals will help us make sure that we're making good use of everyone's time in this particular technical work group. The organized delivery system models that we've been discussing in our larger, broader stakeholder group, those are, generally speaking, as we saw at the meeting on Friday, those are a piece of what we need to consider, but there really is a broader conversation that we will need to have about how do all the pieces fit together into an organized delivery system, and to think about, what innovations have already been developed, and how can we further develop those innovations into a system that can provide whole child care and provide the right incentives for good quality care, access to the right set of providers, and being cost effective. Of course, we need to make sure that our models are not projected to spend any more than what we're currently spending for the system overall. So those are the goals that the department has for the CCS redesign effort, and I think they do intersect nicely with this particular work group. And again, I want to emphasize that the department, the administration, we know that there are many outstanding questions still about what will things look like in the future, but we also know that there are a lot of great ideas out there, and that we have quite a bit of alignment on the overall goals of whole child care and access to medical homes, and making sure that kids have access to the right set of providers. So again, I know there's some worry and some concerns about, what does this mean for families, and we want to make sure that people know that we're going to have a full and transparent process to discuss that. Okay, so with that, I'm going to go to the next slide. This is listing the members of our group here on state and county roles and responsibilities. And there is a Word document that we've attached that's marked draft that I believe everyone should have access to. And it is essentially a description, a high-level description of funding for the CCS program. One of the things that we had, Judith and I and Louise had talked about before we got on this call was, this work group might want to look at ways that we could either expand this document or look at other documents to really describe for anyone to know exactly sort of what is the current funding structure and access to information about, current funding levels, but also description of what are the activities that those funding levels support. So again, on the next slide, there's information about that and the link to the Department of Healthcare Services website that has the allocation of funding for county administrative and medical therapy programs. So I think the overview and the information for folks to start looking at. Judith, is there more that you want to say sort of as opening thoughts or comments in this kickoff webinar?
Thank you, Anastasia. I think you put it really nice. I think we feel it's really important as the state and the stakeholders are looking at any kind of changes or whatever model we may go to, that everyone understand how the current roles are, how they currently work, so that we can make educated, informed decisions as we move forward to not disrupt care as we go forward.
Great. And Luis, is there anything you want to add as far as the documents or?
Right, and I echo what Judith has already said and what Anastasia has said, but to put a little bit more information on it in terms of the funding structure for the CCS program, as Anastasia says, intersects with the state very well, but over the years in this 80-year plus program, there have been a lot of complications and developments in other programs that have complicated the way that the program actually works to make funding smooth, including different programs like the Healthy Families program in previous years, the Medicaid program, even though we take that for granted in terms of it being in existence in 1964, really added a lot of complications to the program. And of course the Affordable Care Act, and more recently, and the changes to the Healthy Families program in the last few years as well, all add complications in how things work in terms of funding the program. So it is very important in the near future that we do fully explain what those funding structures are, where we actually have minefields and issues, and I know one of those is the county MOE, maintenance of effort, that's been capped at about, total in aggregate, it's about $49 or $50 million. And we know that that amount has been exceeded by the counties by almost 100%. So that those issues need to be addressed down the road, but it needs to be made clear what those funding streams are. So again, just echoing what has already been said in terms of wanting to really learn more about the funding for the program.
Great. Okay, so is there anybody on the work group that wants to make any other comments or add thoughts?
This is David, and Luis, I appreciate you kind of acknowledging, that we've got a bit of a broken system. It's not just about improving processes or systems, but we've got some fundamental challenges in terms of state-county financing issues, and some real challenges in terms of state-county roles and responsibilities. And I think for me, just walking into this conversation, it's difficult to have this conversation about talking about improving state-county processes when in fact we're talking about significantly changing the whole model of service delivery. And I think part of maybe what the conversation also needs to be is what are the appropriate roles for the state and the appropriate role, if any, for the county in a future CCS program that's focused on whole child care and integrated care. And I think that's almost a more fundamental conversation before saying we can do eligibility a little bit better or we can do case management a little bit better. Who should be doing what? Your question, and how does that get financed, and how do we work out all of those arrangements?
Well said, yes. I'll take that back and give it some further thought.
This is Diane. So I wanted to add another layer of complexity that has come about. Well, I guess it's been around for a while, but with the ACA and the new 100% reimbursable aid codes and the relationship within the state with the fiscal intermediary and the lag time to convey changes in a large system has been problematic in a number of ways. And I think most people on the line understand that, you know, we have policy issues that change rates of pay either for hospitals or subgroups of CCS eligible clients. And then there's a lag between the implementation of when that occurs and a probably extended lag until there's systems changes that can accommodate those payment changes. So it creates, you know, problems of having to track individualized claims by funding source, and it just, that adds another layer of complexity for the program.
Thanks for raising that. Good. Please, is there more? I'm just thinking of our. It sounds like we're you know, in our focus on how to, you know, document what's currently happening. Sounds like that might be something that we should think about as far as documenting in the current system, what the lags are and how do we at least describe those. And of course the next step would be about what changes we might want.
Right, absolutely, and I agree, and I would say that, yeah, this is work that clearly we're not going to be doing today. This is a kickoff meeting, and that in the near future, we definitely need to work at identifying all of these issues that are complicating the program for the counties, that are impacting cash flow to the counties. Diane just mentioned one between the payment system, the FI, the Department of Reimbursement, and issues to resolve those systems issues and system fixes that need to be done. So clearly we'll be reaching out to the smaller group via email and other phone calls to get that thing going.
Are there any other, so I think we're at the point on this call now to start making a list of to-dos as far as, you know, documenting or summarizing current issues. So we've got, we're going to do further work on the document that we put out, the Word document, further describe funding, and also just programmatically we want to do a little bit more detailed description of exactly what the county responsibilities are in each of the several areas. And then we're going to describe the fiscal lags and maybe do a paragraph or two on that to kind of describe what's happening there. What other areas would folks to, and we can work jointly with the counties on this document. Certainly they don't have to be all just from the DHCS perspective.
Right. Are you still talking about the funding context or
really,
or others?
It could be funding or programmatically, but you know what, and you know, especially for folks on the call who are not you steeped in the detail of state-county interactions, for the public as a whole, are there other ways that we can describe the current system, the current funding, that would be helpful for others to hear about as well?
This is Christopher West. Yeah, I'm just curious. Well, yeah, so it would be, it's kind of echoing what I think it was David that said, but given the new role that some of these children's hospitals will begin to play, I wonder, what the county's role will be. So it's I know that the role of this call is county-state roles, but it seems pretty clear to me that it's almost like county, state, and then these major children's hospitals, or whatever other model we end up going with. So the clarity of the relationship between those three organizations financially would be helpful as a citizen and so forth, who to go to for what. I feel like that's just what David said, but I just wanted to say that as well.
Thanks so much, Chris. Yes, and definitely very much similar to what David had raised, and we do need to, as we further develop models and as we think about options for the stakeholder process to consider, definitely we need to kind of find a way to intersect the options for what the county role would be with the options for what health systems, hospitals, and managed care plans would be.
Anastasia, this is Judith, and just I thought Christopher's point was excellent. And just to kind of take that a little further, I think when he mentioned sort of financials at the end, I think you and I think it'd be helpful if we could put together sort of a short reader's guide of what the roles of the county CCS programs are now and how they interact with the families and the providers, just sort of as baseline. But I think going forward, that future role of the county obviously is going to depend on what kind of models the state model or models decides on, and then whether that is risk-bearing again. And so in other words, the future role of the counties is going to be partly dependent on whether a new delivery model assumes risk or whether they don't assume risk. So it's almost like we have to be looking at different potential models in order to be talking about what a future role of counties might be.
And Judith, just to add on to that, I think it's not only that, but it's, if a model presumes that a chunk of the population is not dealt with in the model, then there's a whole segment of the population that still needs to be managed as well, and figuring out how that happens, and if sufficient resources are available for us to actually manage the remaining components.
This is Ann. It seems to me that it can work both ways too. It kind of, me, a little bit, it depends on what's the priority, right? The relative merits, and what do people think of the relative merits of the county's role now in terms of doing utilization and care management? And is that an overriding priority to be addressed, and therefore the models have to accommodate that? Or is it that the model is the priority and that the county-state relationship has to accommodate that? I think it's kind of the latter, but I'm not sure that we've actually been explicit about that.
Thanks, Ann. Yeah, that's a very fair question. Mm-hmm.
And I also say that we actually, just in terms of our proposal, tried to draft our proposal so that it could be flexible enough to do either, but that we would not accept it, and we would not think that anybody would want to accept capitation, whether it's a managed care plan or a hospital or anybody else, if in fact the utilization review and care management was divorced from responsibility for the risk. So.
Right, because who would want to do that?
It's a difficult situation just financially to be in.
Yeah.
Great. These are all good thoughts on the sequence, the conversations and the discussion. Is there anything else that we can I just want to make sure we're all clear on as far as documenting the current roles and processes, because, if we think about changes, we really want to make sure we're not leaving out a certain piece. One thing that came up at the network technical work group was credentialing of providers, and again, I wanted to, just for clarification purposes of what the current process is now, and forgive my ignorance, but Luis, is that a state responsibility, and is there a county role right now there?
Yes, it's a state responsibility in terms of paneling providers. So the providers do apply to us. You go through the application, and we will assess and determine whether that specialist is CCS eligible, and we approve it. We do the same thing with facility sites as well, hospitals, NICUs, EICUs, et cetera.
And then, Anastasia, the county role in that process, which oftentimes will receive a referral for a service that was rendered by otherwise eligible CCS provider, and so we actually coordinate the provider to get paneled so that they can continue to treat the child. So we just we walk them through the process to get them up to the state. So that's the piece that comes our way sometimes. Sometimes the provider is not quite paneled yet, and so we find them and send them up.
Thank you.
Not by looking, but because we got a referral.
And in addition, the counties have the role of providing feedback to the state where we have concerns about service delivery at an approved facility or provider.
Yeah, hi, this is Christopher West again. I don't want to get too far abreast because I know we're only a half hour into this call, but because we're talking about providers in my homework I did for this project, and so forgive me if this is a dumb question, but I understand that cost is a huge issue, and so one thought I wanted to bring when we began the discussion of anything regarding durable medical goods or providers was whether there was a single source statewide. So this would probably be a state-coordinated thing in terms of possible providers or medical goods in different areas to allow counties to take advantage of market forces and so forth. Like perhaps there's a better provider that a given county doesn't know about. I don't know. It might already be the case that that exists, but wanted to make that suggestion at this point since this topic came up right now.
Thanks for bringing that up, and we definitely in our previous conversations at the stakeholder group and then in other visits we've been doing, we know that DMA is an important topic. Luis, can you kind of give an overview of what's the state's responsibility versus county responsibility? Is there a DME versus other types of services or benefits?
Right. I think it's because of the way that the program is structured today, meaning that we have dependent and independent counties that does get involved in supporting the dependent counties in that role. So we do receive requests from dependent counties in trying to assist in that area. That was an issue that was very problematic several years ago in terms of DME providers and trying to get that service to CCS children. And I know that the independent counties also are involved in that area, but because we don't oversee the independent counties as much and we're not involved on a day-to-day basis with them, I defer to the independent counties and maybe ask Judith or David or someone else if they could respond to that particular aspect.
I don't know that I am informed enough to do that. It may need to be one of our county people.
One of our CCS administrator level people,
Yeah.
probably.
Yeah.
So Susan, do you want to take a shot?
Just as a clarification, all I'm speaking about is information access. So it seems to me logical that that the state would hold responsibility for a statewide list of authorized providers, and durable medical goods providers, and that list be heavily publicized to all the counties so that everyone has maximum access to possible providers and medical goods for competition's sake.
Chris, I understand what you're saying now, and you're right, that doesn't exist in today's environment, and something that, yeah, you're right, we need to kind of put on the list and let's consider it. You're right.
Okay, great.
Chris, I'm glad you raised that. As Louise said, we'll definitely put it on the list of things to, again, we should document sort of what is the current process for DME, and then, as you say, think about options for changing that, because it's a subject that's come up several times. So obviously we need to make sure that we address.
And I would say that, this is Diane, it's become quite challenging to get some DME in some counties. It used to be, when the reimbursements for the providers were a little bit more robust, that it was more of a competition for providing services for CCS kids. But with the reductions in reimbursement because of the rollback from Medi-Cal, it's been very challenging to get some medical equipment and some DME. And we've gone through processes at the executive committee of developing letters that we can provide to families saying that you're eligible for this DME, but we're unable to find a provider to provide the DME, and as soon as we can, you can have it. So it really is challenging. It would be great to have a centralized list where we knew people were willing to, provide the service at the rates for CCS. So.
And it sounds like that might be something we can even do sooner than, at least getting the list there, yeah.
It would be a much more efficient process, and the families would probably get served much faster in some places.
Great.
So Anastasia, I did this task where I thought about the different areas where there's intersections between county and state responsibilities. And I don't know if you want me to just say the topic areas, or if you want me to hold on that for a while because we're in some other area. So tell me how you want me to proceed with that.
Sure, that would be great. And again, we're not going to make any decisions per se on models on this call, but just to have an inventory of either topics that you think we need to dive deeper into, or just at least to consider. However you want to. Glad to hear it.
Okay. Well, I'll start with administration. And so to get our spending authority, there's a process we have, and that's to prepare and submit an annual plan and budget. And with that annual plan and budget comes a certificate of compliance stating that we understand all the rules and regulations for the CCS program, and the county is saying we are going to comply. So that kind of puts the compliance requirement in our ballpark. And then the state responsibility, I think it's shifted over the years, and I think it's maybe shifting back. Luis, you can confirm this, but there was a review. There's been a review process since 2008, but prior to that, there was an approval process for the plan and budget that was submitted, and dialogue back and forth to make sure that the budget met the criteria that the state was expecting to see from the counties. So that approval process initially, along with the compliance certificate, is what allowed us to invoice our quarterly invoices for payment. And then with the diagnosis, treatment, and therapy funding, where the counties have to complete a certificate of county appropriation, and that goes through our auditor's office generally for signature, and then it goes to the state, and that is also held with the staff at the state that do the claims adjudication, the quarterly claims adjudication, and issue payments to the counties. So, and then in the diagnosis and treatment services, obviously we all know that CCS we assign the aid codes based on the primary Medi-Cal aid codes and the CCS aid codes, how they mesh. And then we authorize services using service code groupings and procedure codes. And then the state through the fiscal intermediary, pays on those services, pays on claimed services from authorized providers based on the client's aid codes and the service authorization. And then subcategories of that for organ transplants. Locally, we coordinate with the transplant center and authorize transplants after we've received approval from the designated physician at the state that approves transplants. And then they work directly also with the transplant center. And then out-of-state treatment services. For instance, when we have a client that we're providing services for and their particular medical condition requires a service from a provider, say in Cincinnati, because that's, it's so discrete a medical condition and treatment protocol that that would be the place that they'd go. The county's responsibility is to assure that that service is not available in the county, and then we forward that to the state with basically the work that we've done, and they would approve the out-of-county service, and they would coordinate billing if that entity that the child was sent to was not already a provider that accepted Medi-Cal payment. And then we also have emergency out-of-state treatment, like if a child that has a residency in California is in an auto accident in another state, and there's an eligible condition, and the child is referred to their resident, then we work with the state to coordinate payment for those services as well. Or if we have children that are already part of our program who are traveling and they get sick, in Orlando, Florida or something, then we have to work with the state to also have them work with the fiscal intermediary to get the payment piece together. Bone marrow transplants. The county determines medical eligibility, and we estimate the cost of care by working with the special care center or the facility, and then we have to request a 100% reimbursement if we're a county that meets the criteria, which is a population of 600 or less. I'm sorry, 600,000 or less. Yeah, so there's some criteria around this, but we have that option for CCS only children and for 100% state reimbursement. The state provides the approval letter, and they provide the county with a modified diagnosis treatment therapy bone marrow transplant invoice for those services, and then we're able to invoice through the first couple of years of that treatment. And then with the therapy program, the therapy programs that operate as outpatient certified rehab centers, basically in the county, we have to establish and maintain, I'm going to use the acronym OPCR standards, and then the state approves and monitors the MTUs for the OPCR adherence, and then we're able to claim for therapy services, physical and occupational therapy services, based on the rates that are approved. And then there's a relationship on the backside of that where the monies come to the county, and the county returns 75% of those revenues to the state, and we're able to put 25% of those revenues back in the program. And then for new medical therapy unit facilities, sometimes we have to expand and move to different areas, or sometimes there's just a need to move to another area. At the local level, we start the process of identifying the facility and looking at the standards for facilities for the medical therapy program, and then we move it to the point where it looks like we know what the facility is, and then the state has staff that come and actually do the review on the facility and approve the facility. And then not often, but sometimes, and I think it's become a little more common with MTUs aren't signing interagency agreements with the CELPAs anymore. So there's kind of a little backlash that the items that the CELPAs ordinarily pay for sometimes are not being paid for because there's no agreement in place. So I guess the counties would submit a request and a justification for approving purchases that are designated to be the CELPA's responsibility in the interagency agreement. And then the state evaluates and approves, denies the purchase. They always have a stake in it as well, 50% cost. So. And then the CCS appeals process. financial, residential, medical, and benefits eligibility. At the local level, we verify the administrative due process has occurred, and we verify the appeal criteria, and we address all the first-level appeals. And then the state, they actually track our first-level appeals, and I'm glad to see that we got a call last year, and that did happen, to see what the categories are. And then the state level, they would conduct any fair hearings, any of the appeals that weren't resolved at the first level, and they would conduct the fair hearings. Some counties have their own counsel. We have an option to ask the county to provide, and the state to provide counsel, and they coordinate the administrative law judge, and they coordinate the hearing. So that's as far as I got.
Quite a bit.
Yes, that's excellent. Thank you so much. I hope it's helpful for others on the call. There's some important nuances here that, again, we'll work writing, but think about as far as you mentioned, the appeals process, and even on medical therapy, that there's even a role for the state there as far as confirming the facility, approving the facility. So it's a very close interaction. Is there anybody else that wants to add any other sort of piece to what Diana has described, any component that folks are wanting to learn more about or want to make sure that we have documented in our current map?
This is Susan, and it's already been mentioned the role the state plays in approving providers and facilities. And then I know there's another work group looking at the issue, but providing the guidance around medical eligibility and helping to achieve consistency is also a function of the state, and that consultation to the counties when we have a question about a case that might be a new treatment modality and whether or not that should be covered, and fostering collecting that necessary medical justification and sometimes presenting that to state medical providers to review and help us determine whether to cover or not.
Thanks. That's a great point. Yes. I think we've maybe been taking that for granted a little bit because of the other work group, but that's a really good point to bring up, make sure we've got it. Okay, so we have a to-do that DHCS will work with Judith and David, Susan, Diana, the county folks on this work group to develop further documents, and I don't know if it'll be one document or more than one that puts in writing these details so that everyone can see, and then we can figure out, as far as options and mapping to new models, how these current responsibilities would intersect with the new models. Is there anything more that anyone on the call wants to ask or suggest?
Hi, Anastasia. This is Jessica. I just wanted to chime in here. If you look at the slide, I wanted to point out the proposed... Hello? Hi. Sorry, I'm not sure what that was.
That was me. I'm sorry. I accidentally put you on hold.
Oh. I thought I had dropped off the call.
Sorry.
Okay, so I think we're back. The point I was trying to make was just to pose the question to the group. It's the second bullet on the slide that's currently showing in Adobe. It's the data specifically that would be needed potentially to address some of the issues that have come up. Specifically pointing out the fact that there is the data request form available for this technical work group to make requests of the data technical work group. Just posing that question to the group as to what specifically, well, first pointing out that it's available, but then also if you wanted to have a discussion about specific data to look at.
Thanks so much. And since we have a discussion already going, I believe, with our eligible clinicians as far as data to look at what are the results across counties, I wanted to make sure people were aware of that request already. So are there any other requests that you all might think of that would be, it could be directed either to DHCS or Stanford as far as data that would be helpful for this work group? And I should also add that, as you may see in the Word document, we're compiling the annual dollars for various components and what is the county share and the state share, et cetera. So that's not exactly the type of data request that would go to our data teams. It's more of our fiscal teams would compile that data. But at any rate, are there more data that folks think we should be looking at or gathering?
And this is Luis. I would say also that just to remind people that if this is it's not just a one-time request, so that if you have questions in terms of a data request after the call or then tomorrow or next week, you can feel free to go ahead and ask that. It doesn't have to be today.
Indeed. Thank you for that. Really appreciate that. This is Chris Wex again. Should I have that? Because I'm sure I will have a brainstorm at some point. Where should I direct that to?
You can send that to, I believe you have Jessica's email and mine. This is Anastasia.
Okay.
And we will make sure that we get that.
Because I'm certain there are a few data factors that we're not all thinking of right on the spot, and I'm guaranteed to come up with one or two in the future.
Yeah, and Chris, and I think you may be also joining us for tomorrow's group. I'm not sure.
Yeah, I will be.
Yeah, and you'll see from the purpose of tomorrow's group on medical homes and care coordination, there may be a different set of data you think would be helpful for that as well. So, yeah, anytime, just let us know.
Christopher,
Thanks.
actually, just to make a quick correction, the data request form should actually go to Michaela Ferrari, but because I think you were only recently added to this group, you wouldn't have the form itself, and it would be something that that we can send you via email. The data request.
Yeah, I appreciate that. Okay, so what you're saying is it's a little bit more of a formal request. Fair enough. Yeah, go ahead and send that to me. I appreciate it.
Right, and so Michaela Ferrari, who's staffing the data technical work group, can send that to you. And another thing that I would want to note is the fact that these are prioritized across all the different work groups, so it does go through a process for getting these types of
Yeah, and I'll keep it. I'll do my very best to keep it specific to the work group's intention.
Great, thank you.
Okay, great. So again, are there any other questions or thoughts that folks have? Chris, that was a great thought on the DME. Anything else anyone has?
Well, I wonder if I don't know how much people know about the CCS only population that we serve. It's a small piece of the large pie, but I'm wondering if it would be helpful to have more the financial characteristics of that group or their ability to access care based on their immigration status. And, I don't know if people want to know about that discrete population and kind of what the administrative requirements are to serve that population, or if the thinking is that we're just talking about the Medi-Cal component, and I'm assuming it's the OTL, ICP, and full scope, no share of cost, regular Medi-Cal.
That's a great point. Yeah, we will at DHCS. This is Anastasia at DHCS. We'll see what we have. One other piece I wanted to mention that reminds me is when we think about state-county relationship, often we're thinking about, funding and how does funding flow and levels of responsibility, but there's also an IT infrastructure there as well. We should just maybe touch on briefly so folks know. I don't know if Diana or Luis, either one of you, want to give us a 2-minute version of how information, like how the data is transmitted back and forth between counties and the state, and then, how does it work for dependent counties versus independent counties?
Luis, do you want to do that?
I'm not, you know what, I'd like to defer it to you for now, but because I think about it a little bit.
Well, and Susan, you too. You're pretty in the middle of this.
Sure.
So, yeah. So we use the data system Children's Medical CMSnet, and with a really close relationship using the Medi-Cal eligibility, Medi-Cal eligibility something
It's
system.
You're right. Medi-Cal eligibility data system, correct.
Data system, correct, yeah. So in our world, everything we do is sort of built around the individual client's financial status, as presuming that residential eligibility is established and medical eligibility is established. So we communicate all of the eligibility criteria, the principal client demographic information, and our authorizations. We have a case narrative component in that system, narrate all of the activity that we do, and much of the information that goes into the narrative is automated based on what we data enter into the system. And that we all have access to that and can look at information when a child is open into our county, and I imagine that the state is able to do that because of their relationship with dependent counties, that they jointly can see their cases. So with Medi-Cal eligible kids, the kids who are in, what do I call that Medi-Cal? The one that was here first. That's not OTLICP.
Right.
Healthy families?
Right.
Well, no, the pre-healthy families group. That basically the health access program primarily. I don't know what. You know who I'm talking about, right?
Yeah, we can call it the Title 19 group.
Oh, yes, let's call it Title 19, yes. So with the Title 19 group, most counties try to have some communication with families who have been referred to our program. Oftentimes we don't, because many of the services that we authorize after the services already occurred, and so we have the payment responsibility, so we pay that way. The really sick kids we obviously have much more interaction with and work more closely with the families, but they are not required to meet many of the administrative requirements that the other portions of the population are. So we can authorize without having any contact with the family, as long as we can verify that there's eligibility for the child. And oftentimes we do, until we can catch up with them to talk about what our program's about and that. Then there's the Title 21 population, and with that population, it's treated very much like the old Healthy Families population, where counties and state have a shared financial responsibility of 17.5% each of the cost of services for those children, 65% covered by the federal government. And with that group, we do attempt to identify whether or not they meet financial eligibility of $40,000 a year criteria that we have in statute, and if they exceed that, they're coded to be paid 100% by between the state and the federal government. And then if they're under, then we share in the cost of all treatment expenses for those kids. So with that population, we try to make more of an effort because, believe it or not, we really care about saving as much money as we can so we can spend money on the kids who need it. It seems to be able to expand our population when we know that we don't have any control over that category anyway. We may certify that we have certain money in there, but they keep paying on that category whether or not we have put our county knows that we're spending that money. So. And then with the CCS-only population, the kids who have no Medi-Cal eligibility, either because they have their own insurance and they don't need Medi-Cal, or they aren't eligible for Medi-Cal because of income, but they're from a family who still, well, I don't think we'll see this much anymore, that didn't have insurance. And then families who do have insurance meet the $40,000, families who whose out-of-pocket is going to exceed 20% of their annual income, and children who don't have the immigration status that allows them to have Medi-Cal eligibility. Now, some of that population we can get eligible using PruCall, but that's generally a very small segment of the population, very, very, very sick kids. And so most of the population is not on PruCall. They're in straight CCS. And with that group, we do have to do eligibility. Sometimes we can do it via fax and over the phone. Sometimes we bring people in because we have to sign a PSA, a program services agreement, and we want them to understand a little bit more about the documents that are coming their way, how they need to be prepared when they go to the provider's office with an authorization in case they don't have it, that they will be getting a BIC card. There's a number of kind of idiosyncrasies that are unusual to that population that we try to inform them about. Susan, do you want to fill in anything? I kind of forgot where I'm going.
Well, I appreciate you raising the issue of identifying the county role of determination on our straight CCS population, because that can be quite labor-intensive. Regarding the question about IT systems, Diane has addressed that nicely. The only thing I would add to that is that many local programs have developed also records retention systems to electronically retain documents around these children's cases, limiting the hard copy and paper storage requirements, and those are not shared systems, but rest in the individual county that has created them. So just add that IT complication.
Right. This is Louise. I just want to add that one thing that wasn't mentioned is situations where counties have identified an eligible child for CCS, and initially is a state-only CCS child, so that the reimbursement, therefore, the services are between the state and the county, but later that child is determined to be Medi-Cal eligible, which then means that the counties have reimbursed for services and otherwise for that child that later need to be adjusted because they're really not appropriately to be paid by the county, should be paid between Title 19 funds and State General Fund. And that's been a real problem in the payment system that then requires something called an erroneous payment correction process, which becomes very, very complicated, ties up county funding, and so that interrupts county cash flow as well. So that's an area that you didn't mention, and
thank you.
That's a problem.
Yeah,
that is a problem.
Yeah, and I guess to add to that, I love this program, and I don't want you to think that it sounds terrible to say this, but the funding is limited. We all know that we have a limit that we have to reach, but eligibility is not. We can't stop. We can't not do program eligibility for a family that meets eligibility criteria. So essentially, we don't have controls over how much we spend, and we don't have controls over limiting the number of people that are in the program, because if they're eligible for the program.
Although theoretically, CCS is not an entitlement program.
Correct. We're not funded like one, but
right. I mean, it's been treated as such, but it's not an entitlement program.
Right.
Very good. And certainly understand that these are important issues to document and consider as we move forward. And, it's a very sensitive topic as far as, what is the funding level and how does that line up with, expenditures and making sure that we're keeping track and complying with budget authority, et cetera. So I think it'd be great for us to keep working on documenting all of this so that we're, setting a good foundation for further discussions on this. Great. Well, this has been a really good discussion, and very much appreciate having all of you on as, and lending your expertise to this effort. Is there any other topic that folks want to raise as far as a description of the current process or current status?
Well, this is Diane again. This isn't about, this is not a comment about the current status so much as, where we're looking at going in terms of intensifying case management and more categorizing some of our patients that need more than just medical case management. That it occurred to me when I was driving home after those discussions from our last meeting that I'm thinking that because it doesn't, parts of that care coordination or, the assessment and planning and delivery of services isn't really required to be conducted by a skilled medical professional, that perhaps the plus part of case management is probably more certified public expenditure reimbursable than FFP or the 50/50 non-enhanced activity, even if it is performed by a medical professional. Does that sound, that was kind of a question that came to my mind. I'm wondering if that sounds like we should consider anything like that when the discussions go further so people can accurately represent financially what might support that activity.
We can add that to our list of things to follow up on. Yeah, we'll
Thank you.
Discuss it internally and see what the rules are and how that maps up with the program. Great. Yeah, I think that's a good point. Great. Well, it's been a great discussion. Really good to have all of this laid out and described so well by all of you. So Judith, we will then work with you as the lead contact as far as further documenting current status, current issues, current processes.
Certainly.
Great. All right. Anything else before we wrap up the call?
Hi, Anastasia. This is Jessica. I did see one question that came in through the chat box, and then had a few things before people jump off the call.
Terrific, and I apologize for yes, please go ahead and read the question on the chat box.
So this question comes in from Chris McSorley. Sorry if I mispronounced the name. And he's saying, I'm new to CCS, and I'm wondering why are there CCS paneled physicians that do not serve peds, and why are there so few paneled? I'm not sure I understand the question, but
so it sounds like the question is maybe something about an individual, a family that is having trouble getting access. Maybe you can send the message to that person that they can send an email to State Department of Healthcare Services. I think Louis should send it to the redesign mailbox, or is there someone else that you'd like them to contact?
They could send it Why don't they send it directly to me?
Okay.
So have them send it to me, my email address, and then we will handle that.
Great.
Okay.
This is Norma from Del Norte. I'm just listening in, but I can relate to Lake County's dilemma because up here in Del Norte, we have basically almost 0 panel providers that serve peds. And so just trying to get anyone up here is difficult. And I mean, all of our providers have to be vendored out. And when we're looking at very vital services, like say even physical therapy for our MTP kids, we're looking at having to hunt and fish way outside of our county, like Shasta, or even going further south, like past Humboldt to Mendocino and Sonoma. I mean, it really does make it very difficult when we are small, rural, dependent counties with little or no providers that actually serve pediatric. I mean, you name it, they all have to go out of county, way out of county.
Right. So this is Luis. I just wanted to ask you. So did you have a recommendation for that, or are you just raising that as an issue that we really need to consider in redesign?
You need to consider it in redesign. I mean, it's an imperative issue right now for those of us up here. I can't speak for those around the Bay Area or even Sacramento, but for those of us that are even far more remote up here in way Northern California, the true Northern California, I mean, you're looking at the fact that it's something that you should definitely consider, not only now in assisting, I think the state should assist the counties in trying to find these pediatric providers, because quite frankly, some of us just, it's not in our job description and we just don't have the time. But also, it's something that you should consider in your redesign.
Very good point, yes. And I'm glad you brought that up. That was a comment that we also got in our provider access work group, and rural access is definitely a key issue.
Anastasia, I think I would say that there's 2 things with that. The rate reimbursement for a standalone provider office, individual providers, private practitioners, is challenging with some of the more complex children, so they have a tendency to either limit the number of kids they have in their practice or not serve CCS kids anymore. And then secondly, the administrative burden of fee-for-service claims payment. A lot of the individual provider offices don't have the electronic payment option, and so they're kind of stuck in doing the claims payment. So that's also an administrative burden. And
also the fact, go ahead, I'm sorry.
Go ahead. No, go ahead.
Also the fact that, I'm going to have to be honest and blunt here. The program has a bad rep with providers and vendors. And part of it does, a main part of it has to do with the reimbursement rate. I mean, we took a major hit, especially up here, when due to budget cuts, the reimbursement rate was severely cut. And so you can't attract PED providers to save your life. And also the way the program is administered now, the complexity of the referral process, and all the way to the authorization process and payment of claims. The providers and even vendors really, they get turned off by it. They say it's too cumbersome, it's too complex, it's way too slow. And quite honestly, and this is a major complaint from parents as well as providers and vendors, especially providers and vendors, is that they don't get copies of authorizations or denials. I mean, at the county level, we don't generate them. That's done for our dependent counties. That's done at the state level. And I can understand how busy state regional offices are. However, when providers and vendors for months on end don't know the status of an authorization, that can become a problem, and that also turns providers and vendors off.
I think it's really important for the listeners to differentiate that there's a different process for dependent counties and independent counties.
Definitely.
So some of what you're talking about doesn't occur with independent counties.
Oh, I can imagine that, but I think but when you're looking at
Definitely.
looking at a redesign, you're
Mhm.
going to have to factor the. I mean, definitely the differences between dependent and independent counties has to be noted, but you still have to take all of these issues into consideration.
Certainly, and that's definitely a point that has been touched on in the larger work group with the group that met last Friday, as far as how will an organized delivery system address these issues. So I do want to acknowledge what you're saying and the issue you're raising, and that it is something that is really, fundamental to think about as part of this redesign effort.
Thank you.
So I have one more
Hi,
question.
oh, I'm sorry.
Go
Go ahead.
No, it's okay. Go ahead.
Okay, so this is Christopher Wex again. So just one more thing I wanted to add. This could be applicable in any work group, but I just wanted to say this here that I think that because this is such a big redesign program, that that adaptivity should be a portion of what is factored into the program itself. And by that I mean something that can evaluate and change the program, like something built into the program that initially can. So we're talking about state and county relationships with regards to CCS, and so we're all a very thoughtful group of people trying to think through it, but it could just be the case that we're all wrong about one or the other measures. And so what I would like to suggest is that built into the program is a measure of adaptivity that allows us to change what we think we know after things roll out. So for example, allowing the program to change after some amount of time because the program doesn't exactly fit what we thought the theoretical fix would fit. Does that make sense?
It does. And and it is very consistent with the goals that the department has for CCS redesign. We want quality measures. We have a work group that I think is going to be meeting April 10th to start that. But sometimes those quality measures can take a long time to collect the data and to be able to measure against a baseline. So the other thing that we have done in the department for other efforts is rapid cycle quality improvement, and so finding ways to basically sort of check in, and whether it's particular regions, particular types of consumers or families, and get that data on a quick turnaround basis so that we can identify if there are issues of concern, and as you say, make corrections, provide appropriate oversight, and give additional guidance or technical assistance, or sort of more going in a deeper level of oversight if needed. So very, very important point. Yes, agreed.
Thank you. That's great. I mean, I would almost. I work in the private sector, and I just almost assume that my first idea is going to be wrong. I just would hope that that like redesign would be an almost assumed part of the program, and so I just wanted to mention that.
Great. Thank you again. Very good point. And you're right. I mean, it is certainly a broader topic than this particular work group, but, we're just really glad for any and all input. And, we're taking notes here on how to make sure that in any documents or what have you that the state releases about, further details on our goals or minimum requirements, that's important to include that there.
Terrific.
So this is Jessica again. I wanted to add that we are receiving a lot of really great feedback in the chat box, so I wanted to say thank you to everyone, and we are documenting all of these different comments that are coming in on the subject. So thank you, and we will, UCLA will package and forward these on to DHCS, so we're making sure that everything that's coming in to the chat box will be relayed over to the group. But I did have one additional question that came in from Sarah Copeland. And it looks like so she is a Deputy Health Officer from Santa Clara. And her question is, has the topic of billing private insurance for MTP-only kids, been discussed as a venue for compensation?
Luis, do you have any thoughts on that?
No. Can you read the question again, or the comment?
Sure. So it has the topic of billing private insurance for MTP-only kids been discussed as a venue for compensation?
Many times.
Who's that?
That's Diane.
Oh, go ahead, Diane. Can you elaborate on that?
Well, oftentimes our medical therapy program kids have private insurance, but because of IDEA, there's been resistance to, or maybe there might be a legal barrier to being able to bill insurance folks. So, and there would probably also need to be some, we'd have to have agreements with the different insurance companies and that kind of thing. So it seems like that kind of an effort would need to be coordinated at a state level, so each county didn't have to do individual, contracts.
Okay, so we've put that as an item for either documentation or potential follow-up.
Good discussion, yeah.
Jessica, are there other questions you think in the chat box that should be aware of?
So I don't see any other questions, but before, if there are no other questions, I did want to point to the last two bullets on the slide if you wanted to go over that with the technical workgroup members before jumping off the call.
Thanks. Great reminder. So, yes, we have regular check-ins with Judith, Luis and I, Judith, just as far as making sure we've got agenda topics tracked. And I know we're scheduled to meet biweekly. Jessica, does that mean that we have a date on the calendar 2 weeks from now, or do we need to still schedule that?
So this actually, after the kickoff webinar, what happens is you will receive, you meaning the co-chairs and the members will receive a doodle invitation to try to coordinate schedules and schedule it. So it has yet to be scheduled, but you will be contacted shortly by me, Jessica.
Okay, great. So, and I don't know that we necessarily need to be strict about meeting this group again in 2 weeks, but to the extent that we can wrap up the documents and documenting the issues that were raised as well as the just overall description of current processes, we'll try to push those out as soon as we can, regardless of next meeting date for this technical group.
Right, and then the other note to add, I just wanted to point out the fact that the dissemination of results and findings of this technical work group are expected to inform the May 29th meeting that you brought up, Anastasia, which is the next board meeting with the larger group. So just something to keep in mind.
Correct. And as we go through April and early May, we'll touch base with this group about the key issues that we want to forward up to the larger group. And again, to the extent that we have information and materials that we've shared here with this group, we can send them via email to the larger group so that everyone is aware of information that we've documented. Great. Okay. Jessica, if there are not any other questions on the chat, I think we should wrap up. Judith, is there anything else you want to add as we're wrapping up?
Nope.
Okay. Great. Well, this has been a great call, and thank you to our county partners for joining the call, and thank you to our CCS parent for joining the call as well. We really are very glad to have your input and participation.
Yeah, happy to be here. Thank you.
Wonderful. Hey, everyone. Well, we'll look forward to talking to you or listening tomorrow morning at the next work group and in subsequent groups as well. Thanks, everyone, for your participation today.
Thank you.
Recording has paused.
Jessica?